Welcome to Mayo Clinic Q&A. Thanks for joining us today. I'm Dr. Helena Gazalka, and we are filming this segment on August the 10th, 2020. Well, today it's time for another update on COVID-19, and here with us, as always, is our COVID-19 star, Dr. Greg Poland, who's a virologist and infectious disease expert at Mayo Clinic. Thanks for being with us today, Dr. Poland.
Yeah, my pleasure. I'm in my research office today instead of my home study, so it looks a little different.
I see that. And I see that your wife isn't there to keep that as clean as she does your home office.
Yeah, she's having appointments, so.
Well, thanks for being here, Greg.
Yeah.
I just wanted to start out with a question today. I've heard the term viral shedding used frequently, and I'm wondering if you can explain what that is for our lay audience.
You know, what happens is that we get infected via the respiratory route, and we have these viral receptors that line our respiratory route. That's how it infects our cells. That's an ongoing process, and while that's happening, people can speak, cough, whatever, and that virus be shed and expelled out, which is how the next person or persons get infected. That usually doesn't go on for more than a couple of weeks or at best. But for some people, it looks like they are shedding virus longer. Now, the tough part here is we don't actually culture the virus. So I can't tell you that they're shedding virus. What I can say is that the genetic components of the virus is what we test for, and that's what we're actually detecting. So we have to be a little careful when people say, well, I'm shedding the virus for months. We don't have any proof of that at this point. We just know that they test positive for those genetic components. So that could be old disintegrated virus, for example.
So universal precautions, good hand washing.
Absolutely,
masking.
Yes.
What do we know about asymptomatic COVID-19 cases and why they occur? I know you're always good for a little update on the medical literature.
Yeah, well, this is something that we're really keeping a close eye on. It's apparent that when you look at the whole population, the majority of infections are asymptomatic or pre-symptomatic. Most of them will go on to develop symptoms. For younger, robust people, they may not even realize it unless you very closely question them. You know what? I did feel kind of fluish over the weekend, is what they'll say. Or I had a headache, and normally I don't have headaches, or lost my sense of smell, or whatever it would be. It's the older people, and by older, I mean 30, 40, etc., that start having more symptoms. Past 50, they're the ones that start getting severe disease and hospitalization and deaths. But it can happen to any age person. And I think that's been one of the difficulties in people understanding the seriousness of this. Just because you're asymptomatic doesn't mean it's a benign disease. It can be and does do cellular damage to you. It can affect your brain, your heart, your lungs, virtually every organ, and you may not know that. And you have the potential of spreading it to other people who may have more severe disease. So, I think ultimately what it takes to know is testing at a level that we don't currently do. So the ideal thing would be to take a large group of people and test them very regularly. Now that's being done, for example, in professional athletes, but I'm talking about in older people and working people who are not as heavily sequestered from others. And those are the sorts of studies that need to be done to determine how long are we seeing people infected, and how long from the time of infection to asymptomatic to pre-symptomatic to symptomatic in different age groups, because it's apparent it does vary by age and underlying medical condition.
What you said about the difference in how it might affect one individual versus another reminds me a little bit of like the common cold or upper respiratory infection during the winter. I'll be certain that members of the household, that we're all passing the same bug around, but I may have it for 7 days and my husband only for 12, or vice versa.
Yeah. Well, it's interesting that you say that, because like coronavirus, influenza virus is something that tends to affect males more severely. In fact, in general, that's true for respiratory pathogens. While women actually, the latest studies show that women actually acquire the infection more often, but men are the ones that are more often having severe illness, hospitalization, and death. In fact, the mortality rate about 70% higher compared to women. The other thing that I'm certain we're going to see, because it's been true in every vaccine that I've tested, is that women will develop better antibody responses than men. My wife has suggested a reason, but it's not a scientific one. So,
what is the latest, Greg, about the possibility of reinfection? And are people now getting COVID a second time?
that's a really tough question. You're asking the ones that are right on the cusp of our current knowledge. I think I will come out saying this: reinfection is going to happen. Whether it has happened so far is unsure. So when you look at antibody levels, the half-life for COVID-19 antibodies is right at about 70 days. So by 70 days, half the antibody level has been lost. That's pretty typical for most every virus, so that's not too surprising. What is surprising is that exponential decline appears to continue for some time before leveling out. What we don't know is what level of antibody keeps you protected. Once we understand what's called a correlate of protection like that, it'll make vaccine development and following the science of this easier. Right now, even after somebody recovers from COVID, I tell them, I don't know that you're protected, and I don't know for how long. So at some point, people likely will have a low enough antibody level, if that's the marker, that they could get reinfected. Now, we're hearing case reports already in the popular media, even in the medical literature, of somebody who had symptoms, was infected, all the testing showed they had COVID-19, symptoms resolved, they got better, tests turned negative, and then the test positive again. Well, did they get exposed and we happened to test them on that day? Or is this evidence of a reinfection? Honestly, we don't know yet. And that's something that's going to have to wait for kind of these longitudinal, long studies that we were talking about earlier. Right now, all the effort is going into understanding the immune response, testing antivirals, plasma, vaccines, et cetera. But that's an important study that needs to be done.
You come and tell us about the discrepancies in testing and things we don't know. And then every week we're going to ask you if we have a cure yet, or if we have a preventative. So I'm wondering, an interesting thought, is there a possibility that any older vaccines that have been developed for other diseases, such as tuberculosis, which is a bacteria, or polio, which is another virus, that they could be helpful in finding a vaccine that will work for COVID-19?
Yeah, this is an interesting question, because there have been a number of retrospective observational studies that have suggested, as you said, BCG, polio, MMR vaccine are in some way protective. I have a hard time believing that biologically. It depends on what's called an indirect immunologic effect. In other words, you get those vaccines, your immune system is, quote, revved up, and you are, because of that, your body prepared to fight off that virus. But that means that you would have gotten the vaccine in a time period in relationship to getting infected with COVID-19 where that would work. And of course, that's not what these studies are showing. So is it actually a marker for better health care, for higher, socioeconomic status? Is it a marker for an immune system that can respond well to viruses? We just don't know yet. These studies are happening now. In fact, one is happening at Mayo, where they're looking back at MMR vaccine to determine, is there a differential in who gets infected. But I caution you, these sorts of retrospective and ecological studies are fraught with confounding variables that can lead you in the wrong answer. I think if we're going to seriously consider that possibility, then we use, let's just pick MMR vaccine. We use MMR vaccine in the same way we would a candidate COVID vaccine or an antiviral. We do a randomized study and we do it prospectively to see if there's any difference.
It does seem like it would be difficult to separate out all the things that have happened in a person's life and how it might influence
Exactly.
their development of COVID after having a vaccine, usually as a child or
And
young adult.
there's so many other factors. Your gender, as we talked about, your age, body weight, smoking, other medical problems that you might have, blood type. I mean, there's lots and lots of factors. There's just recently published a study looking at some young men who had very severe disease. And of the four, one died. All four of them had a mutation and deletion of a really important viral receptor called TLR7. So it is apparent, and we're seeing case studies now where many family members, related family members, will have severe disease or hospitalization and death. Those are almost certainly genetic markers that are accounting for that susceptibility.
We've learned so much, but there's so much that we don't know yet. It's really interesting.
You're right.
All right, I've got another fascinating question for you. We've been hearing for a long time that losing one's sense of smell can be an indicator that that we are infected with COVID or that the patient has developed COVID. And we call that anosmia in medicine. And I'm wondering, is there any explanation yet for why that happens? And how long does it take to go away if it does?
Yeah, great question. You know, that's a sign that showed up pretty early in the outbreaks. I have had that side effect myself, although in this case from influenza infection and sinusitis. A new study just came out actually looking at this from Harvard, elegant work that they did, showing, and this is good news, that it is not the virus attacking the olfactory or smell detecting neurons that are being destroyed. If that would be the case, it would be unlikely that you would recover your sense of smell. But people are recovering their sense of smell in weeks to months. It can be variable. What they've shown is that it is the supporting cells around those neurons. There are structural supporting cells. There are blood vessels and the cells that compose that feed these olfactory neurons. It's those cells that are being damaged. And fortunately, those cells can repair and multiply and replace themselves. That's why they're recovering their sense of smell. But it is a very sensitive sign. Other things can do it, but it's a sensitive sign of this infection. So certainly a listener that would develop and notice sudden loss of smell, that's an important finding that should be reported to your physician and investigated.
That's really interesting, and it's encouraging to hear that the sense of smell likely should recover.
Yes.
It's amazing how much that can affect your life. I have a couple of patients who have lost their sense of smell for other reasons other than COVID. And they have told me how very disruptive it is to your life not to be able to smell things or taste things, and that things taste funny after you lose your sense of smell.
What's interesting, and just from personal experience, I did not recognize it at first. It was my wife noticing, you don't seem to be commenting. I always comment on the smell of, her getting dinner ready or of the dinner, and I was eating less. And actually we had gone on vacation to Florida, and I realized I couldn't smell the salt water and everybody else could. And that's how we picked it up.
Do you have anything else you'd like to share with us before we go today, Greg?
Yeah, I think this is more a plea, as I often do, for people to really take this seriously. In the last 2 weeks of July, we are now aware of almost 100,000 kids who have gotten infected. And, I follow the numbers regularly so that we know whether cases are increasing or decreasing. We have gone from 4 million cases in the US to 5 million just in 17 days. The previous million only took 15 days. So this is a very rapidly moving infection. It will search out susceptibles. What can we do other than role model and plead with people? This is a serious infection. Simple things like wearing a mask properly. And I thought I'd demonstrate it again today because it's really important. What's called donning or putting on a mask, I don't touch the front of my mask. You see that I have the nose piece crimped. I put it on and I make sure that it's below my chin, above my nose, and there as little air seepage as possible. This does nothing. You may as well not wear a mask. I've used this mask today, so I'm not going to do it, but I've seen people put it on backwards. These masks are constructed to be worn with the blue side out and the white side on the inside. And you take it off the same way you put it on. You don't touch the front of the mask. Once the mask gets wet, you discard it and you get a new mask. Something as simple as that and washing your hands could protect you or your family or somebody you love or a neighbor from getting hospitalized, from having a permanent disability, and even from dying. So this is really important. Then there's the routine part of life. We want our kids to go to school. We want to go to work. We can't do that very effectively when there's this much of the pandemic still around. And, unbelievably, we still hear of these very large public gatherings, for example, where people aren't wearing masks, or states where there's no mask mandate. This is perpetuating the pandemic. And until we get serious about it, as a nation, individuals take it seriously, but until we do it as a nation, we're going to continue to be faced with this. This is not going to go away.
Thank you for that illustration.
Yeah.
I think I very commonly see people with their mask below their nose, which seems a bit counterintuitive when I think about how you test someone by putting a swab in their nose.
Exactly. Well said. Exactly.
Well, thanks so much for being with us, Greg.
My pleasure.
We appreciate having you here. Thanks to Dr. Greg Poland, a virologist and infectious disease expert at Mayo Clinic. And thank you, too, for joining us today, learning a bit more about COVID-19. We wish you a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.